you'll experience some relaxation as long as you learn to breathe from your belly. With kids, we actually have them lay down on my carpet with a little rubber ducky, and we make the rubber ducky move. With adults, sometimes we'll do it this way to teach it. For this purpose, usually with the adults, I'll teach this to, I just want them to take deep breaths. When they take the deep breath and they exhale, you say whichever one of these phrases you picked. And you use the entire exhale to say the phrase, God is love. God is love. And with your eyes closed, you're meditating on that phrase, that verse, whatever have you. You're focused on your breathing and you're focused on the words you're saying and the meaning of them. Now here's the key. First of all, if you pick a Bible verse, pick one you can say in one breath. People have that favorite verse and it's like 50 words long. It's one of Paul's longer run-on sentences. You can't get that out in one breath, which means either you're going to fight it and you're going to get the William Shatner voice and you're going to get anxious because you're out of air. Or you're going to say, well, I'll do half in the first exhale, I'll do half in the second. Are you going to be thinking about your breathing? What are you going to be thinking about? Which part of that verse am I on? You're not going to be relaxed. So pick a verse you can say in one. These ones that you'll see on the Bible passage 1 or that way. You'll see that for the passage of the character, the very short statement. The second thing to be very aware of, distractions are going to happen. That's actually important that they do. If you're like me and you're used to squirrel moments, perfectly okay in this case. You want those to happen because if you actively avoid them, you go, oh, I can't do that. I have to do my relaxation. It's like the banana thing. You'll pay attention then to the distractors. And you'll be thinking, oh, I stink at this. And you're gone. What you want to do is notice them. Acknowledge that the distractors happen. Wow, I'm thinking about bologna sandwiches right now. That's funny. And then back to the breathing and back to the passage. For me, I often imagine the ocean. Tide comes in, I experience it touching my feet, and then it goes out. I can't stop it. I can't control it. It's going to naturally go out. I'm just going to experience it. How often, if I'm thinking about bologna sandwich, I'll picture the bologna sandwich going out with the ocean. For me, that allows me to stay in that meditative state. I teach clients to do this protocol. Typically, if you're seeing me for traditional therapy, you're going to do it at least 3 times a week, at least 10 to 20 minutes per time, preferably daily, but initially, since most clients feel really awkward doing this, they won't do it daily. Because then they're like, okay, I'm doing the breathing thing. And it feels weird at first. In the famous words of Bob Benefield, you kind of have to fake it till you make it. But it gets easier and it gets better. So here's the study. I have a good and a bad problem in my clinical practice. I have a waiting list. It's good in that financially I know I have people that want to pay for my services. It's bad because I have a number of people I'm not getting to anytime soon. There's just not enough treatment professionals in this area to meet the need. And when I refer, there's not enough referral sources to meet the need. So the reality is that I have a waiting list. I decided after seeing this lady that, well, I can't get all these people off my waiting list, but I wonder if I could do this study with them. They're getting something. And I imagine some of these people would leave the study to go into my treatment list. I wouldn't make them finish the study. If I had a slot, I'd just move them over. So I picked more people than I thought would actually finish the study. That's often how we do a waiting list control in clinical research. In this case, they all finished. So you'll see a very unwieldy data graph in a few minutes. For single subject design, which is the clinical research I most often do, the benefit of it is you can do a small number of people. Frankly, you only need 3 people to do a single subject design study. And it's a small number of people that you run through experimental conditions. So you get the benefits of experimental controls, but you don't compare mean versus mean. You compare people and their response to people responding. It's truly clinical in that nature. For that purpose, because you have to have internal validity, you have to get your inclusion criteria, who's going to be in the study, and your exclusion criteria, who you're kicking out, really well defined. For my purposes, they had to be diagnosed with GAD. It is a study looking at the benefits for GAD. I picked adults. The reason I picked adults is the literature that we have on mindfulness meditation suggests very inconsistent results with children. And once you get past elderly year 65, the results get sketchy. Since we don't have a robust body of knowledge, I played conservative there. They've got to be able to say the phrases, so I needed verbal people. I do see some clients who are selectively mute. That wouldn't work for this stuff. I also wanted people who are currently emotionally stable at some level. They were certainly distressed from their anxiety, but they weren't psychotic, they weren't struggling with reality testing, and they weren't experiencing high levels of neuroticism related to lethality. Lastly, I needed people that are currently stable in their treatment process. In this case, none of them were getting treatment, but I used exclusion criteria. If they were, they hadn't had any big changes that would create a compound. So as we got going, here was the process. I ended up with 7 people in my single sub design. I needed 3, had 7, all 7 finished. This is a multiple baselines approach, meaning they all start baseline at the same time, but they're going to enter treatment at different times to control for confounds that are due to life circumstance and situation. We used an A-B style, meaning they had a baseline, then a treatment, then they returned to baseline. They stopped doing the meditating. And they then ended and they returned to treatment. They're on my waiting list, so I didn't want to end with withdrawing treatment. Not an ethically comfortable situation. And so I didn't know when they would be able to be seen for traditional treatment, so I wanted them to at least have the intervention going at the end. The process was this. I called up these 7. I said, hey, I can't get you in anytime soon, but I'm starting a study, and I wonder if you would be interested in being a part of it. If you are, I'll offer you a training session of 90 minutes in Christian devotional meditation. Then during that session, I had a script for teaching them the rationale, teaching them the method. We used God's character instead of the Bible passage one. And then I made them show me they could do the process. Could they work through that script? When distractions happen, could they do the activities that are going to help them stay in the mindfulness process? Now, they don't have to be effective yet. That takes time. But they had to be able to show that they could do the protocol. And so we would assess that and make sure that by the time they left, if they were going to be in the study, they were able to do that. All 7 could. And then the goal here was every day during the treatment phase, when they were in it, they had to be doing this process. When we went to the withdrawal phase, they were supposed to stop doing the process. We included, for the purpose of single subject internal validity, fidelity checks. We would verify with them during the baseline periods that they actually were not doing the activity. And when they were supposed to go back into returning to treatment, we would verify that they actually had gone back to doing it. Now, we did rely on self-report. I didn't camp out at anybody's house. That would be awkward. But we did check on it, and in this case, we had 100% reports of fidelity. We also did accuracy check, because every week they were administered the Beck Anxiety Inventory to assess for generalized anxiety, and we checked my scoring. We checked whether I had filled it out right, and clear right. We had 100% accuracy with a third there. So the things that we do in single subject design for internal validity were effective in this case, and they were present. As far as the group, we ended up with 3 males, 4 females. Interestingly enough, just a quirk of the draw, inclusion criteria required that they all had GAD, but none of them had any comorbid disorders. That's very rare. I got lucky there. Usually with anxiety disorders, it's very common to have a depressive disorder or another anxiety disorder to boot with GAD. In this case, they all exclusively had GAD upon verification of their diagnoses. Also, somewhat fortuitous, none of them were currently getting any treatment at all when they entered my waiting list. None of them were on any anti-anxiety medications. None were receiving adjunctive therapies, anything like. No one even tried the metabolic kind of, things that you get from CVS to help. They're really blank slates as far as treatment. Incredibly fortuitous. Usually that's not what you see. You still do the study, but I wouldn't have expected that. So here's what we found. You have no ability to read this. With there being 7 people data on here, you're going to have to trust me a little. I'll send you the data if you want to see it. But there's no way to make this visible in a way you're going to get it. And I didn't want to print it out and waste trees. If you want, I'll gladly send it to you to have it. But I didn't want to take the chance you're going to throw it out. I've wasted a lot of trees this past week. And so what you see in the data, you basically see over here for 7 people, 4 different treatment conditions. Baseline, treatment, return to baseline, return to treatment. what you can see, hopefully at some level, is each of those people kind of experience peaks and valleys. For an AB approach, that's what tells us that treatment was effective. When they were in baseline, they had high anxiety scores. What you can see for all 7 people is when we initiated the Christian devotional meditation, all those scores came down. Different rates of coming down, different levels of response, but they all came down. Now we did something next because they're on a waiting list and I can't do a pure treatment, baseline treatment post. We had to measure stimulus control, so we withdrew the treatment. During their time on the waiting list, we contact everybody and say, now I want you to stop doing the treatment. Again, hard to see on there, I'll send it to you, but what we saw, those low scores turned into higher scores. Higher scores mean more anxiety. Most of them did not go all the way up to baseline again, some of them did. Meaning that for most people there was some maintenance level from doing the meditation. They didn't go all the way back to where they were before the intervention. But some did. When we then reinstituted the treatment to show stimulus control, the anxiety scores again went down. Often they went down further than they went the first time, which also suggests some maintenance. When we measure single subject design studies, the first thing we do is we do a visual inspection. That's what the visual inspection said. Nowadays, we can do statistics on this stuff. In the old days, I would look at that and go, yeah, you should just trust me, this is what it shows. But now we can statistically show through simulation modeling analysis whether those slope differences or those level differences are due to chance, or whether statistically they're due to something else. We ran that on here. We ran the analysis last week, so I have added them to this graph. It's actually really hard to get the text box on there. I just ran out of time. I can get that to you as well. But the interesting thing, the exciting thing that we're going to be providing as an addendum for some of the publishing we're doing with this is that for each of the baseline to treatment conditions, there was statistical significance at slope change. Not all for level, because in many cases there were incremental changes. So we wouldn't expect a level difference. But the slope, the trajectory of the data, statistically significant for all conditions, for all people. That is awesome. At least at the 0.05 level, there were a couple that were at the 0.02 where they had a drastic slope. But at least at the 0.05 level. That's really exciting. A, it's exciting because the treatment seems to be working. We're all for that. I frown if I'm doing things that stink. At least at treatment. It's embarrassing. But also, this is exciting because usually for single study design, people are only now starting to use this statistical stuff. And when you have 7 people, it's easy to go, well, how do you know that really was true? Well, at least I can say for these 7 people, it wasn't due to chance. And we try to control the confounds for internal validity to say the only systematic thing that varied for these people was whether they were receiving the treatment and when. So it should be the treatment that caused the change. Very exciting for us. I've been doing faith-informed integration research while I'm working on a textbook for it. And there's shockingly little research that's done with statistics at all, besides 18 out of 20 people reported some satisfaction, basic 4 out of 5 dentist degree kind of stuff. We're real excited about what we're finding here, particularly because now it's going to allow us to ask other questions. Does this form work better? Does the Bible version work better? Does it work better for folks who are highly religious or highly spiritual or both? There's all kinds of things we still need to know about this that allows us to tailor treatments very specifically. But a good first start for us. That's the research. It's very simple, very problem-oriented kind of research. What do you want to talk about? What questions might you have?
On your graph there?
Yeah.
It looks like the second, between the second box and the fourth box.
Yeah.
There was a very precipitous decline the first time around, and not so much in the second. Why would that be?
It can be a number of things. The most likely reason, having been involved with each of these patients, at least looking at the data, and for those of you who are going, hard to see. I'll send it to you. But he's right. A lot of times what we'll see is when someone makes a dramatic response in the first treatment section, sometimes you've tapped out the window for how better they're going to get. And so even when you reintroduce, it's about bringing them back to their therapeutic level. versus what their baseline was. And so looking at that, the most likely thing is, they had, as you can see on the movement up, they moved almost all the way back up to their baseline. And so they really had to use that treatment time to get back to where they had made the gains before. Chances are that's the maximum amount of gains they could make. Other times, it's just a matter they have to undo my withdrawal of the treatment.
Gerald, JR, you talked about this for generalized anxiety disorder. Did you go out in the literature for pastoral counseling also and see if it's been applied in various situations in pastoral counseling?
There's a lot of stuff in pastoral counseling for non-clinical samples. There's nothing out there that we looked at. You looked at all clinical settings. I looked at the pastoral literature. We didn't find anything clinical where they had verified a diagnosis or were working with a diagnosis. They weren't using the VI, they were using non-clinical anxiety scales. We didn't find anything clinical. But there is a lot of stuff on Christian devotional meditation, mindfulness meditation, in that venue for non-clinical, for the everyday anxiety we kind of experience.
What kind of follow-up for generalization and maintenance do you plan to do?
In this case, none. What we'd love to do in a future study that's a little larger, where we can pull people that are durably distributed using the Counsel and Care Center resources. This was done before the stability of that center really having regular manpower. Now we can utilize. In the future study, probably still is a single study design, but it's more of an ABA style, where we have a baseline of treatment and then a follow-up phase for assessing maintenance. I'm not sure, given the numbers we have of people with GAD through the counseling center, that we could do a between groups or anything like that to measure maintenance and compare means. I'm not even sure I really like that anyway. I'm definitely a single subject guy in my philosophy. But definitely would like to do an ABA style where we can focus on maintenance. In this case, I was most worried at the time that they were never going to get a slot in my practice, so I had to finish with treatment. But we'd like to follow a study of similar population and do that.
How about the back? Giving the back later again?
Yeah, same thing for maintenance. Now, for the purpose of this, since we don't know how far it maintains right now, you'd want to be giving the vet anxiety inventory regularly like we were during this study, and so we probably need to have good access to it. And long term, where we just have a number out in space, it's hard to define that that's a maintenance variable and that there were no confounding variables that led to a separate anxiety valve or something like that. And so it'd be hard to utilize that, but we'd really like to do an ABA study where we could really park in, and we've used the back anxiety inventory for that. It's great at measuring generalized anxiety. Not so good at some of the somatic methods, but really good at generalized anxiety.
So I want to go back to the bananas. It's
All
clear
about
in
the
the
bananas.
pretest, you can see that in each case, there's sort of you have some increase in anxiety. But then they experience improvement. I assume they are aware of improved decrease.
Mhm.
So when you tell them to stop, how do you, is it the breathing? I mean, what is it about that doesn't have some kind of effect where they, in fact, if they're saying God is love, that even you tell them to stop, that in their heads, they're still not thinking God is love.
What we can do as far as the measure is say they're not doing this protocol. The one downside to any clinical research where you've taught someone skills is you can't completely eradicate the skills. And so you look at what the data does. When we look at baseline, all of these people at baseline, if they were faith informed, had said things like that before. They had narratives in their head from time to time. Well, God's good. Why am I experiencing this? My God loves. I hear that every Sunday. Why is my life so crappy? You know, whatever it be. What we find in this case is we're measuring getting the full protocol versus getting not. There's been a lot of research to show breathing alone versus breathing with the words. Breathing with the words works better. When we do meditation, breathing alone will definitely help. That biological aspect underpin will definitely help. In that withdrawal condition, there's no way to completely unlearn the intervention. You have to allow that there's some residual responsiveness. What we look at is the trajectory of the data. Did it return, was it heading back up, meaning it wasn't enough, the protocol really was necessary, or do they kind of stay where they are? Just having that life knowledge was enough. I see that a lot in therapy. I'll treat someone with therapy, and when they experience sadness again, something in their life is going to trigger sadness again, they'll use the things they learn even though they don't come back and do therapy. That's enough to keep them maintained. In this case, we see that at the absence of the treatment, they're going back down or going back up. And so in this case, they're going back up, increased anxiety. And so even if they were using those skills a little that they had learned, it wasn't enough. And so looking at the protocol for reducing was important there.
So is it the words that you're using, or is it the technique? Because my question would be, is it semantics? Does this work if I just say anything else?
No.
Okay.
We've played around with that. The research shows that we've done studies where we'll have you say nonsense things. The switches are wiggly. That was one that I remember looking at. I don't know if a switch is really wiggly, but even we have you say mundane things. The road is paved. The breathing will lead to some relaxation. The breathing alone will do that. It's biological and hardwired thing. The matter is return on effect. What we often talk about in terms of response to intervention incrementally. You do one intervention, you get this far, but if I add this to it, I get this much more. That's what we see when we add faith-infused language for people that experience religiosity and spirituality at high levels. They tend to get more out of saying the words. Now, we also find they respond to this differently. People that are highly religious but not as highly spiritual, you know folks who their religious behaviors are primary in their faith walk. Doing those Bible passages not nearly as effective as doing character words. On the other hand, people that are highly spiritual, they can do either and feel perfectly fine and get just same response. So we do find the words matter, but they also not only matter for adding them to the intervention, but they matter based on the client coming in. And we'll see a different response based on that. So it doesn't seem to be purely semantics. Now we do find for some clients, the type of character you pick or the type of verse you pick matters. I do a lot of work with survivors of trauma. You have to be really careful about what verses they pick there. Some of my clients come in and say, I want you to pick a verse, and they'll pick some fire and brimstone, Deuteronomistic principle type verse, which immediately gets them, I deserved what happened to me. Well, that's not going to be relaxing at all. Not only is it not true, but it's not going to be relaxing, not going to be functional. And so, definitely the words have a great power here. If you ever want to read good work on this, read the work on relational frame theory. It comes out of the acceptance and commitment literature. A guy named Steve Hayes. But our language is actually how we form our understanding of the world. Most of you don't think in pictures, you think in words. And that's very important for how we understand. And so that's why the words definitely seem to matter, and picking them well matters. And the research has kind of borne that out.
JR, just back to that thing about the words. Suppose you have sort of a generalized humanistic phrase that you offer somebody, whether they're religious or not. I'm assuming there have been plenty of studies clinical in that area.
Sure.
How would this compare to that?
The main thing we see is if you do mindfulness meditation from a non-Christian manner, particularly as a Christian, clinically it will work just as well in the anxiety. Now, we didn't know that till we do the study. That's the presumption based on all the other studies that have been done. You have to do it to know it. In this case, it matched that. What we see, and hopefully I mentioned this earlier, it's an important point, is that for people who are religious and spiritual, Muslim, Christian, you pick it. If we pick a faith-infused method that matches their tradition, not only will they get the clinical benefit they get from the intervention either way, but we see a wellness benefit. Instead of just getting not ill, they seem to get even better. They seem to experience higher life satisfaction. Quality of life indicators go up. Their perception of being well goes up. All those things are important for immune function, they're important for flexibility for job work, our academic achievement, a whole host of outcome variables. As far as the clinical, their depression and their anxiety, a humanistic phrase for a Christian versus a truly Christianese one, the depression they'll treat the same. We've done those studies. Now we know from an anxiety standpoint has definitely a response in this aspect. We wouldn't expect much of a difference on the clinical aspect.
It's amazing that more work has not been done on this. Because centering prayer has been around, it goes all the way back to the Benedictine tradition, the Lectio Divina, and so on. And
in my EBP class, we actually pull out some of the Benedictine liturgies for prayer to teach for some of those other methods of meditation. Nowadays, they don't get greatly used out of the Catholic tradition for centering prayers, but they're great for some of these other methods we used for meditation. With non-clinical samples, there's a robust literature.
Yeah.
I don't have a great explanation for why it's taking so long in this area. I'm sure part is, when I was trained initially at a Christian school. I was taught not to bring faith into the clinic room. We didn't, it's not our specialty, go get the pastor. And frankly, we didn't have literature like this to tell us how to do it. One of the benefits, in our program of teaching students those things is they learn proven methods so they can feel more confident doing them. We haven't had that for a long time. We're just really getting that point where the evidence-based perspective is coming in.
Is there a tradition in the Baptist faith and tradition about uncentering prayer or anything like that?
I'm not aware of that.
Yeah, in Baptist tradition, there's the idea that meditation is just an Eastern kind of phenomenon. We don't really do that. We're more of a left brain sort of.
I was telling Elizabeth before this, I used to try to do centering prayer and mindfulness meditation with my patients down here before I kind of found this Christian protocol. And it was an abysmal failure. The minute I said the M word, clients went wiggling. And they'd say all kinds of, I know you're not from here. I mean, all kinds of things. When I was able to take the M word out and utilize this protocol, using the same principles that we use in Buddhist meditations, more secularized ones, not a hitch. Not a hitch at all.
Because it's one of the really big deals in my faith tradition, the tradition of centering prayer, particularly in what we call Eucharistic adoration and things like that. I'm not real good at it because my mind wanders, so the squirrels come in, as you would say. But I know a lot of people who do practice it well.
And in Anabaptist traditions, it's very prevalent as well. In fact, we rely on some of your writings.
So part of this, you're doing this clinical to establish more on the scientific side than the pastoral care, because at the previous institution I was at as a dean of the psychology program in my area, we had masters in Christian counseling and masters of psychology. Both led to the LPC, but we had to be mindful that Christian counseling was not tell somebody to get their Bible, read this chapter, sit in the closet in the dark, and do that.
Right.
I mean, that's what we have people doing in the Houston area. So is that what's driving you?
In many ways, that's an ulterior motive of this process as well. I don't speak of it so as kind of ended in there as much as give clinicians like me a language.
Right.
We know terms related to mindfulness. We understand how meditation works. Some of my previous research, we know what psychological acceptance is. We aren't good at translating those into interventions from a faith-infused standpoint that we know can get us to those same goals. And so the hope is to create a common tongue, so to speak, so that that clinician who may not be as well versed in a spiritual language, a spiritual framework as far as how to intervene, now has a tool they can reach for with that client and utilize and feel confident about. And so there definitely is an aspect of that where we hope that by establishing the science of it, that leads to more training in these areas. I mean, you can't even find a good textbook on this stuff. The only textbook on evidence-based practices is a pastoral care one by a buddy of mine named Everett Worthington. There is no psychological textbook for this. Again, I told you before, I'm really good at finding obvious gaps. That's all I do in life. And so that's really been part of the benefit of this, I should say. I don't know if it's been purely the goal, it's definitely a benefit.
Well, that's what drove them to give up the masters in pastoral counseling, because they thought you were training you to counsel pastors. And we went more with the Christian counseling, so the idea was you're treating with a different effect. But anyways, it was real interesting. I just walked into it